Hey everyone. This lecture is going to be going over an introduction to end tidal CO2 monitoring. So what is end tidal CO2 monitoring? What it does is it measures the level of carbon dioxide at the end of exhalation when the percentage of CO2 dissolved into arterial blood, which is also known as your PaCO2, approximates the percentage of alveolar carbon dioxide, which is your PCO2. Therefore, samples of exhaled carbon dioxide measured at the end of exhalation can be used to approximate the levels of your PaCO2. There are different ways to monitor samples of expired gas, including an endotracheal tube on your client, an oral airway, or a nasopharyngeal airway. Normal end tidal CO2 ranges are from 35 to 45 milligrams of mercury. This is the same level when we just looked at your carbon dioxide with acid-base balances. So hopefully the number will be easier to remember. Again, it's 35 to 45 is your normal end tidal CO2 ranges. End tidal CO2 is a real-time reading of carbon dioxide present at the end of each breath. So you will notice a change in your client's end tidal CO2 before you would see a change in the O2 sat. An O2 saturation reading is later. If you are monitoring the end tidal CO2, it is real time what is going on with your client. There are different devices that monitor the end tidal CO2. If you look at the slide up here, the one to the right is our Alaris pump that we're very familiar with, that we do have at Tri-City. There is a chamber that you can attach. Instead of infusing fluids, it's your Alaris end tidal CO2 reading. Now, at Tri-City, I usually do not see a waveform on the main screen, as you can see here, but you will see the reading, which is, if you look at this one, this client's end tidal CO2 is 35 milligrams of mercury. And then you've got the middle one, which they can attach to a bag valve mask. So as they are assisting with ventilations, they will also get the expirations from this client, and they can see if they are perfusing adequately with their assisting with breathing. The one on the very left is called a colorimetric CO2 detector. This has been around for many, many years, and it was the standard that was used out in the field and even in the ER for quite some time, to where this would be put on the end of an endotracheal tube when the client was first intubated to see if the tube was in the correct place. And how you would read this is if it turned gold, you had a good end tidal CO2 reading, which meant that they were ventilating correctly. And if it was not good, it would turn purple. So just remember, gold is good, purple is bad. You see gold, you're golden. So why are we using the end tidal CO2? There are many reasons that we do monitor and look for these values. Because end tidal CO2 provides continuous estimates of alveolar ventilation. Its measurement is useful for monitoring the patient during acute airway obstructions, if they have apnea, if you're weaning them from a ventilator, and an endotracheal intubation. It may also be used for something called hyperventilation therapy, which is done usually in an ICU department, but it is to reduce elevated intracranial pressure. Hypercapnia is a term that you will hear, and this is excessive CO2 in the bloodstream, typically caused by inadequate respirations. You can also use it during CPR status. If there is effective CPR compressions being done, it should show an end tidal CO2 reading of greater than 15 milligrams of mercury. If the reading is less than 15 milligrams of mercury, we need to assess to make sure the compressions are being done correctly. Low end tidal CO2 volume or values of 10 or less may be caused by either poor compression technique or it could be low perfusion and metabolism after a long downtime, despite good compressions. So by watching end tidal CO2 during CPR, it can let you know if your compressions are adequate, and it will also let you know if you had a return of spontaneous circulation. Return of spontaneous circulation is when you get a heartbeat back. Most times during CPR status, if you're doing chest compressions, after a full minute of compressions, we would check for a pulse to see if you have a heartbeat. But with this, if you're monitoring the end tidal CO2 levels, and let's say you're doing compressions and your readings at like 18 milligrams of mercury, pretty consistent, you're doing good chest compressions, the reading is there, and then it suddenly jumps up to 26, stop and check for a pulse, because you may have had return of spontaneous circulation, which is absolutely what we were looking to do. So how is end tidal CO2 displayed? Exhaled CO2 waveforms are displayed on the monitor as a plot of end tidal CO2 versus time, called a capnogram, which provides you, the nurse, with a continuous graphic reading of the patient's end tidal CO2 level with each exhaled breath. Changes in the waveform indicate clinical abnormalities, mechanical abnormalities, or both, and require immediate assessment. On a capnogram, the waveform is composed of 4 phases, each one representing a specific part of the respiratory cycle. If you hear capnometry, this is a measurement and a display of the end tidal CO2 value, but there is no waveform. So if you look back on that second slide with the Alaris pump, if you don't see a waveform on there, it's actually capnometry is what's measuring it. If you see that colorimetric detector, CO2 detector, where the gold is good, that is another capnometry type measurement device, because it does not show a waveform, it just gives a number or an indication if it is within the normal limits. So your first phase is your baseline phase for end tidal CO2. This represents both the inspiratory phase and the very beginning of the expiratory phase, when carbon dioxide free air into anatomical dead space is exhaled. This value should be 0 in healthy adults. So if you look at the figure up here for first phase, you can see it's at the very bottom left of the diagram. It says phase 1 baseline. And again, this is when you are doing an inspiration and right at the point where you start to expire. Okay, it's just the very, very beginning of that. And again, your level, if you are healthy, should be at 0. The second phase is your expiratory upstroke, which represents the exhalation of carbon dioxide from your lungs. Any process that delays the delivery of CO2 from the client's lungs to the detector prolongs the expiratory upstroke. So some conditions such as COPD and bronchospasm are known physiological causes of prolonged expiratory upstroke. If you see mechanical obstructions, such as kinked ventilator tubing, this may also cause prolonged expiratory upstrokes. So your second phase is the rise that you can see in this diagram. And this is again when you are exhaling CO2 from your lungs. So phase 1 is baseline, usually at 0, the inspiration and the beginning of expiration. Phase 2 is when you're still expiring, and then you're going to go on now to phase 3. The third phase begins as CO2 elimination rapidly continues. A plateau on the capnogram indicates the exhalation of alveolar gases. The end tidal CO2 is the value generated at the very end of that exhalation, indicating the amount of carbon dioxide exhaled from the least ventilated alveoli. So if you look at these pictures I have up here, and you can see the lung with all the alveoli that's going on, if you consider that the alveolar at the very ends it's going to take the longest for that CO2 gas to exchange and to be exhaled, that is when you are going to get your reading of your end tidal CO2 reading. When you look at the waveform picture that we have here, you see phase 3 is the plateau, so that is the end of your exhalation phase. And when you finally get the very last bit of the CO2 gases out of your lungs during exhalation, that is going to be your reading, your end tidal CO2 reading. The last phase, also known as the fourth phase, is called the inspiratory downstroke. This is the downward deflection of the waveform, which is caused by the washout of CO2 that occurs in the presence of the oxygen influx during inspiration. So this starts all over again. So you will see each of these phases for each breath that somebody takes. So if you're looking at a waveform and you're looking at over a minute and they're breathing 16 times for a minute, you should be 16 of these waveforms going on with their inspiration and expiration. Again, when they're in the phase 4, the CO2 level quickly, again, drops to 0 until those gases will start to exchange again. Okay, some nursing considerations. Make sure you explain this to your client and the family. Especially for your client, if they are just have the nasal cannula and tidal CO2 device on, they just know there's this funny looking bulb that's getting in the way of them trying to drink, because you see as it hangs down over their upper lip. So let them know the importance of this and why we are doing it. Also, make sure you get a full picture of your client's respiratory status, which means getting a full set of vitals, still get your O2 saturation, and tidal CO2 readings, and an observe waveform quality and trends of end tidal CO2 readings, just to make sure that there is not a change in your client's status. Some considerations also: observe for subtly increased readings, which may indicate bronchospasm or asthma or partial airway obstructions. The waveform takes on a distinctive shark fin appearance when this occurs. So you can see the diagram, and it does kind of look like shark fins when you're looking at it. This is caused because there is uneven emptying of the alveolar gas, which alters alveolar gas emptying onto exhalation. It produces changes in the ascending phase, which is phase 2, with a loss of the sharp upslope. And it also alters the alveolar plateau, which is your phase 3, producing the shark fin. So again, if you have someone that's having an asthma attack or a bronchospasm and you have them on the end tidal CO2 monitor, you will more than likely see this shark fin appearance. Okay, a gradual increase in end tidal CO2, consider hypoventilation. This could be related due to sedation. If the client is rebreathing previously exhaled CO2, the end tidal CO2 values increase and the baseline may elevate. The waveform may not return to 0 at the end of each inspiration. Look for inadequate expiratory time, a malfunctioning inspiratory valve, or other errors, malfunctions in the breathing circuit, or insufficient inspiratory flow rate. We want to make sure that this is not a mechanical issue also. But of course, always look at your client and assess them and see how they are doing. But again, you will see this type of waveform with hypoventilation. So some things to consider if you see a decrease in the readings. It may be a partial or complete airway obstruction, like an airway collapse or secretions in the ET tube if intubated. So you may need to suction your client. It may have a dislodged ET tube. It could be a ventilator that malfunctions. So make sure you check your equipment and make sure the equipment and the tube and everything is in the correct place and doing what it needs to do. If you see a gradual decrease in readings to less than 35 milligrams of mercury, consider hyperventilation with those clients. If you suddenly drop to a very low number and there's a loss of a waveform, assess for apnea. Your client may not be breathing. Of course, make sure that it is on correctly, but be concerned and go look at your client. If you notice that there is a 10% increase or decrease in your readings when you are trending this, let the doctor know, just because there may be something going on that they need to intervene with. So just kind of rule of thumb, a 10% increase or decrease is when you want to let your physicians know. So here is a picture of a normal waveform. Your normal waveform, your end tidal readings are 35 to 45 milligrams of mercury. As you can see, you've got phase 1, 2, 3, and 4. They are consistent with the size. They're in between the 35 to 45. It does not look excessively fast or slow, so the client probably is not hyper or hypoventilating for some reason. So this is what we would like to see in a normal waveform. If you see somebody hyperventilating, which means their respirations are going to increase, when their respirations increase, their end tidal CO2 levels decrease, right? They're blowing off too much CO2. When this happens, if you look at the bottom picture, that will show how hyperventilation may look. You will see there are a lot more breaths on your waveform, and the level of your end tidal CO2 reading is lower. This one looks like it's probably at about 30. Okay, so if they're hyperventilating, this is kind of what that would look like. If they are hypoventilating, you're breathing less, right? Your respiration rates are low. Your end tidal CO2 will go up because you are retaining carbon dioxide because you are not blowing off enough because of the hypoventilation. So this is like the picture I showed a couple slides before, but your hypoventilation, your readings will usually continue to increase until it is corrected, and they are wider because you're breathing less times per minute. So remember, capnography reflects changes in your ventilation, which is the movement of gases in and out of your lungs. It also reflects changes in diffusion, which is the exchange of gases between the air-filled alveoli and the pulmonary circulation, and your perfusion, the circulation of blood through the arterial and venous systems. Okay, so remember, if the end tidal CO2 reading is greater than 45, your CO2 level is high. This is usually caused by something that's causing hypoventilation. If you're hypoventilating, you are retaining your carbon dioxide because you're not blowing it off effectively, and this will make you more acidotic. It is respiratory in nature, so this client will be in a respiratory acidosis. If the end tidal CO2 number is less than 35, the CO2 is low. If this happens, your client for some reason has some hyperventilation going on. They are blowing off too much CO2, so your client would be in a respiratory alkalosis. So hopefully this helps you guys. I will go over this in class a little bit more and answer any questions that you have. And I hope you guys have a great day. Thank you.